Thank you, Don. Thank you to the rest of the CAS board for having me and all the attendees for taking time out on this holiday weekend and joining us. Also, thank you to Seattle Science Foundation and to Broadwater for making all this happen. So I want to talk about a topic that is near and dear to my heart, minimally invasive surgery and lordosis. But first, my disclosures. I'd also like to thank Lobis for their support of this particular session as well as the meeting. And I am going to talk about various devices that I do get royalties on. So how do I maximize lordosis correction? When you have a pristine starting point, the first question you should ask is it better to go anterior versus posterior? And I think for a case like this, where you need to get a lot of correction at 4.5 and 5.1, it's clear that the ALIF approach is the gold standard. Can you turn off the automatic advanced feature? Because it's advancing all on its own. All right, so if I have to go posterior, and there's lots of reasons why I cannot go anterior, it could be medical, it could be anatomic, it could be technically related, or it could just be logistically related, since in California you have to do an anterior approach with a vascular surgeon, so they may not be available. Suffice it to say, sometimes you have to go posterior, but our goals are still to achieve as much focal lordosis correction as we want. And here are my kind of outline of how I do this. The first thing that I do is I spend a lot of time doing a really thorough discectomy to really loosen up that motion segment. If I have to, I'll do even bilateral facetectomies. And because using an MIS approach, the posterior annulotomy window is so small, of all the surgeries that I do, if you want to do an MIS posterior approach and get a reasonable interbody reconstruction, I think you have to use some type of technology that allows you to go in small and get big, because oftentimes the disc space is much bigger than the posterior annulotomy window. And then finally, just like in ALIFs, there are times where no matter how good of a discectomy you do and how good of a facet release that you do, the ALL is just too tight, and I'm going to talk about some strategies on how to deal with the ALL from a posterior approach. So let me just start out with an example. Here's a pretty challenging isthmic spondy. It's got a life of its own, this thing. So how do I treat a case like this posteriorly, where I know I'm going to do an MIS approach, and I'm going to have trouble with the posterior annulotomy window, because right now it's basically bone on bone. This person also has a very steep sacral slope, and there's a big interbody that I have to reconstruct. And the way I do this posteriorly is, I'm going to tell you, but first, let's do this one survey question. So hopefully Seattle Science Foundation has this. Take 15 seconds to answer this and see what people say. I suspect most of it's going to be MIS, because that's the way the Koreans roll. So let's see. Okay, perfect. Just as expected, lots of ALIF surgery. So we'll talk about that. All right, so that particular case I did with a bilateral MIS TLIF approach. Sorry. So can somebody just take 2 seconds to turn off under the animations pane, the use timings feature so that it doesn't go by itself? Because otherwise we're going to get tortured.
Stand by, doctor.
Thanks. We may have to go off of presentation mode. Sorry, guys. We fell for the oldest trick.
Hey guys, thanks for watching. To continue, please log in or create an account for free. Thank you for your support.